Welcome back, kids and coaches. And today we are talking about the knee and its related structures. So this gets us into chapter 16 here for unit 6. So for all of you counting at home, we only have 2 more weeks of class left. So let's get right into it. First off, for the rest of these recordings, I'm going to start off by going over really just the basic anatomy of the body parts. I don't expect you to have a full understanding or appreciation of the anatomy, but you should at least have a general idea of it. And this will help, as you know, all of you fitness and wellness majors get into the human body course, which is BI 210, anatomy 1 and 2. You'll need this when you get into kinesiology, which is FW-140. So it really just kind of sets the stage for everything you're going to need to do here in the future. Now, for your knee, this is a hinge joint. A hinge is just like, the hinge in your door. Your door just opens and shuts. It doesn't close side to side. It doesn't go up and down. It just opens and closes one way. Same thing like your elbow, but your knee, it just bends. It bends back and forth. Now, there is a little bit of rotation that goes on with it, but we're not really going to get into that so much. So 4 bones you should know. You have here your femur or your thigh bone, your patella, which is your kneecap, your tibia, which is your shin bone, and your fibula, which is the bone that runs on the outside of your leg, or the outside of your lower leg. There's a bunch of soft tissues that are in the knee. The ones you should know are really the ones that kind of everyone should know. You have 5 major ligaments that surround the knee, both inside and outside. The 5 ligaments you should know are your ACL, your PCL, your MCL, and your LCL. You should also know your patellar ligament. So your patellar ligament connects from your patella or your kneecap, and it goes to your shin bone. If you feel on your shin, just like if you're sitting down and you feel starting from your knee, like your kneecap, and go down, the first bump you feel is this right here. That is your tibial tuberosity. And what that does is it provides the insertion point for your patellar ligament. Now, the other ligaments you'll need to know, ACL is your anterior cruciate ligament. That's right here. Cruciate means cross. Anterior means front. This pairs with your PCL, or your posterior cruciate ligament. So PCL, ACL. Your PCL runs from the front of your knee to the back of your knee. Your ACL runs from the back of your knee to the front of your knee, and they form a cross. Because these form a cross in the middle of your knee, they prevent your knee from sliding forward and backward. Your MCL and LCL are your collateral ligaments. So your LCL, they have it termed here your fibular collateral ligament. That is your lateral collateral ligament. They also have it listed here as tibial collateral ligament. That's your medial collateral ligament. So LCL, MCL. These connect your femur down to your lower leg. On the outside, so lateral means outside, so this is the outside of your leg. It connects your femur or your thigh bone to the fibula, which is the outside bone you have on your lower leg. For the MCL, it connects your femur, or again your thigh bone, to your tibia, which is your shin bone, but it connects it on the inside, so it's the inside of your lower leg. Because these connect on your sides, they prevent your knee from moving or sliding left and right. So ACL, PCL, forward and backward, MCL, LCL, side to side. You have three muscle groups that we're going to be concerned about with the knee. You have your hamstrings, your quads, and your calves. So gastrocs or gastrocnemius, that is your calf muscle or your big calf muscle. Underneath it, you have a muscle called your soleus, but that does pretty much the exact same thing as gastrocnemius, but it's just underneath it. The only thing that this helps with is helps to bend your knee, but it only assists with it. Primarily, it's going to move your foot and ankle. So that's kind of all you need to know about it right now. Your quads are on the front of your thigh. The name quad means four, so you have four of these muscles. You have vastus lateralis, vastus intermedius, vastus medialis, and rectus femoris. You can't see You can't see vastus intermedius. It's underneath these three. So it's hidden. The only three that you'd be able to see are these three: vastus lateralis, medialis, rectus femoris. Their primary function is to extend the knee. It means it straightens your knee out. So your quads straighten your knee. Your hamstrings are on the back of your thigh. You have three hamstring muscles. Your hamstring muscles on the inside of your back thigh are your semimembranosus and semitendinosus. They do pretty much the same things. And then on the outside, you have the biceps femoris. So you have three hamstring muscles, four quadriceps muscles. The hamstrings primarily flex the knee or bend it. So when you bend your knee, you use your hamstrings. When you straighten your knee, you use your quads. The other piece of soft tissue we should know is your meniscus. Your meniscus are these two half-moon shaped pieces of cartilage that line the bottom of your knee. So they actually line the tibia or your shin bone. They're on the top of it. These act like big cushions that are going to support the force of your leg coming down on your knee. The best way to prevent injury is to fix mechanics and to be in appropriate conditioned shape for your sport. The major injury that you have to watch out for with the knee is an ACL tear or an ACL sprain, you may hear it as. If you tear your ACL, the majority of ACL injuries, over 70% of all ACL injuries, are non-contact injuries, meaning they occur when no one touches you. I tore my ACL in May of 2016 while pitching. I was throwing, I was pitching a ball. My right leg or the back leg that was on the rubber did not rotate while the rest of my body did. So the way that you tear your ACL is if you plant your foot and then you twist your body. So if my right foot, say, stayed straight on the ground, but my whole body twisted away from it, that would be potentially how I could tear my ACL. If you tear your ACL, you have to have surgery. I mean, You can go without it, but at the same time, you're not going to be able to play at a high competitive level of sports, especially collegiate sports, with a torn ACL. And this is something, an ACL injury is typically around a 4 to 8 month rehab process. We've talked about bracing before. So bracing doesn't work unless you have an injury or you have had an injury. So if you're perfectly healthy, if your knees are perfectly fine, you've never hurt them before, they're feeling good, and you try to wear a brace just to prevent, so prophylactic means you're preventing something ahead of time. If you're trying to just prevent an injury from occurring by wearing a brace, not going to do anything for you. You want to ultimately be in good physical shape, so you want your legs to be strong, but more importantly, you want your body mechanics to be sound. If you don't have good mechanics, that is how you get injured. I tore my ACL because I did not have good mechanics. If I would have rotated my right foot, so rotated my back leg, not only would I have been able to throw the ball harder, but I also wouldn't, or most likely wouldn't have, torn my ACL because my mechanics would allow for normal movement of my leg. The other thing you should note about here is this thing called a Q angle. Q angle is known as is short for quadriceps angle. This is the angle that is made between your pelvis, your femur, and your patella. It makes up all the three main attachment points for your quadriceps muscles. In short, a Q angle is going to determine the inherent amount of stability or instability that's in your knee. The smaller your Q angle, the more stable your knee is going to be. So if your Q angle is small, for men, that is between 11 and 14 degrees, you have a much less likely chance of having an injury to your ACL. Women, because you have wider set hips, you are going to have naturally a larger Q angle. Women have about a 2 times greater chance of injuring their ACL than men do. So for women, your normal range of motion or normal Q angle range is 13 to 16 degrees. Because you have wider set hips and your femur comes out farther than a male's would, females have less stability inherently with their knees. Now, some tests you can look at doing here. The Valgus stress test, what he's doing here is he is holding onto the ankle and he's pushing inward and outward on the knee. Because if his knee collapses either way, that's going to mean it slides left or right. If that happens, that is going to mean that you have an injury to your LCL or your MCL, because those prevent your knee from sliding left or right. If you do an anterior drawer test or a Ligaments test, which is much more common now, what is happening here is your knee is flexed and the physician will usually just hold on to your thigh for support, but then he's going to hold on to your calf and pull up. This is important because it is going to test for your ACL. He's pulling up on it, so that is a forward and backward movement. Forward and backward means that you are going to test for ACL health. The best one right now is Ligaments test. Ligaments test is right here. So your leg is being held in the air and you pull upward. There are much less false positives and much less false negatives for the Ligaments test and there are for the anterior drawer test. This whole compression or distraction test, that's going to test for a meniscus tear. What this doctor's doing is he's laying you down on your stomach and your knee is bent to 90 degrees. So this is 90 degrees here, roughly. And he is just pushing straight down on your knee or on your heel to push down on your knee. And in this one, he's pulling it up. If you have pain with this, especially with a compressive one, this here will test if you have a meniscus tear. If you do this distraction test, which is this one, and you pull up, that will say you have some sort of ligament injury if you get pain. You want to perform a compression test prior to a distraction test because a compression test is going to be less painful than the distraction test. And you may guard or try to hold your knee more in place after you do the distraction test. Different functional tests you'll see: walking, running, sprinting, cutting, backward movement. The important ones are walking and sprinting, primarily for your meniscus. If you have a meniscus tear, one of the hallmark signs is your knee will lock in place, meaning that when you're trying to run, instead of your knee bending and extending or bending and straightening, it'll get stuck. So you will actually feel like your knee sticks in a certain position. That's because the meniscus is torn and the bone is getting caught on it. Cutting is going to be most useful for ACL, MCL, and LCL. Backward running is going to get PCL. The cutting and backward movement tests are going to be considered positive, or they're going to suggest you have an injury if you have instability or if you have pain. So that means if you feel like you're not able to do that running, say like you try to cut and you feel like you just can't do it, that would be a sign of instability, or more likely than not, you would have pain. Even for myself with walking, when I had my ACL torn, and granted I had a complete tear in it, so I had no ACL at all in my right knee. And it took me a couple months to end up getting surgery due to the insurance verifications and all that. But I got to the point where when I would say bend over or even try to just get up out of a chair, and if I had to move anywhere except forward, I would have excruciating pain because my knee would rotate out of place because my ACL wasn't there. Now, like I said, with the ACL sprain, and again, a sprain means a tear to a ligament. This here, right there, that is your ACL, and that is torn. You see how that's completely torn off. Where it should be is over there. Or actually, I take that back. Your ACL should be anchored right here. Anyway, the ways that you get this through contact are if you take an anterior blow to the extended knee. So if my knee is extended, meaning my leg is straight, and someone hits me straight in the knee from the front. So if someone comes and tackles me with my legs straight and they hit me on my kneecap. Or if they give me a lateral blow, meaning they hit me on the outside of my knee or even the inside of my knee. Either way, they hit your knee on the side. More likely than not, this is how you injure your ACL. Medial rotation with a fixed foot. So again, your foot is stuck on the ground and your body turns away from it. A PCL sprain or a PCL tear, again, ACL stands for anterior cruciate ligament. PCL stands for posterior cruciate ligament. With this, the only real way that you injure this is from a hyperflexed knee, but then you also get hit on the top side. This brings in Britney Spears. Hyperflexed knee with a plantar flexed ankle is exactly what she's doing here. When you have a hyperflex, so hyper means big, flexed means bent, so your knee is really bent, and you can see her knees are really, really bent here. And you have a plantar flexed ankle. So if you look at her ankle there, plantar flexed means your toes are pointing towards the ground. Her toes are pointing towards the ground. This will happen typically in football. So like say a running back falls down to the ground and they're in this position and someone tackles them from the front side and knocks them backwards. That is what can injure your PCL. One of the last notable people I remember having a PCL injury was Adrian Peterson, running back for the Vikings and Redskins. Usually though, you don't get surgery for a PCL sprain, even if it's a grade 3, which grade 3, that's this, complete tear. And it's usually because it's not as functional or not as much needed. The main thing that's going to happen with a PCL tear is having difficulty with backward movement. If your normal life doesn't involve that, it may not even be required you ever get surgery or even do anything for it. If you get an MCL sprain, this here usually is going to come from a hit to the outside or inside of your knee. So MCL or LCL sprain will get from inside or outside hit. MCL usually accompanies an ACL sprain. LCL usually by itself, it's very hard to injure the LCL. But again, fixed foot with rotation, that's the big one here. If your foot lands here and your body turns away, that is problematic. That's where you're going to have these problems here. For a meniscus tear, again, same kind of things you have with, say, like an ACL injury, you're going to run risk of there. You can also get this from doing a lot of overuse. When you tear a meniscus, your meniscus is cartilage. Cartilage is very avascular. Avascular means that it has a very low blood supply. So if you tore a piece of cartilage, it typically doesn't heal on its own. Less than 4% of all meniscus injuries are going to spontaneously heal, meaning heal without surgery. You typically don't want to get surgery on an MCL until it causes symptoms. There are two things you can do for a meniscus surgery. You get a partial meniscectomy or a meniscus repair. If we look over here at where this tear is, you see how there's that nice tear there. If I had a partial meniscectomy, they would shave out this tear. So they, meaning a surgeon, they would just cut that straight out, and now I just have a smooth surface there. Problem solved. You are usually walking again after like a day or two, back to playing, like return to full competition in like a month or less. Real simple. The only problem is when you get a partial meniscectomy, you speed up the degeneration process of the cartilage in your knee. Meaning, you start the process of getting arthritis at that point. Partial meniscectomy is the best treatment for you short term, worst treatment for you long term. A meniscus repair is where they would go with this tear and they would suture it back together. So meaning they would give you stitches in the knee itself. Those stitches, called anchors, are going to stay with you forever. or at least until they tear out, because they don't last usually forever. But this is your best long-term method because it's not going to take away from the actual cartilage itself. You keep all the cartilage you have. The only problem is that you have to be non-weight bearing for 4 weeks, meaning you can't put your foot on the ground and stand up. That is non-weight bearing. You're on crutches for 4 weeks, and then takes about 4 months to be able to come back to play. Other couple things you can watch out for here: knee plica. Your plica of the knee is this kind of capsule ligamentous structure that surrounds your knee. And if you get a plica synovialis, that just means you have an inflammation of the plica. With this, usually you do nothing except rest it if you have pain. Sometimes if you have chronic pain associated with this, it can actually form these different little tears or segments that fall off, and they can irritate the knee further, which might need to go and get cleaned up, so surgically removed. And then bursitis. Bursitis is where you have an inflammation in your bursa sacs. So those are going to be a lubricating and insulating type feature, it's almost like similar to a cartilage pad, but it's underneath, like within the joint itself. If you get inflammation out there, this is what would happen. Very painful to move the joint, but usually nothing bad happens as long as you use compression and non-steroid anti-inflammatory drugs, so NSAIDs. Loose bodies, that's usually like if you just get anything like that calcifies, or if you have any kind of like bone chips in there. This is what loose bodies would look like. Those have to be removed surgically. There's nothing you can do about it. This is another example of a loose body there. IT band syndrome. Your IT band or your iliotibial band is the common tendon that is formed from your gluteus medius, which is over here, and your tensor fasciae lata, which is there. Those both help to abduct or kick your leg out like you're doing a jumping jack. The IT band is one of the longest tendons you have, but if you get IT band syndrome, you're going to get inflammation and pain to the outside of your knee. That's where you're going to have it. If you don't have pain on the outside portion of your knee itself, you won't have IT band syndrome. And that is everything there. So there's your quick rundown of the knee. That's everything I got for you guys with that. And I will see you back here when we talk about the hip and thigh.